Good evening, everyone. I once again thank the organizers of this event for the opportunity to present before you. The objectives for this particular case presentation are to appreciate the role of pre-procedure imaging, recognizing abnormal substrate on electroanatomical mapping, demonstrate a symbiotic use of entrainment and substrate mapping and ablation within the epicardium. On history, we have a 56-year-old male with a previous history of inferior wall MI who presented with a monomorphic VT needing cardioversion. He had no additional comorbidities. The sinus rhythm ECG showed the sequelae of inferior wall MI without any persistent ST elevation. The echo was suggestive of a ejection fraction of 42% with a persistent right regional wall motion abnormality in the RCA territory with scarring of the myocardium. No aneurysm was noted, no clots were present. This was the ECG of the clinical arrhythmia. There was a QS in the inferior leads along with a delayed time to peak activity from the onset of the QRS, suggestive of a possible epicardial exit. This was a left bundle branch block ventricular tachycardia with a early precordial transition. The pre-procedure imaging done was suggestive of a transmural myocardial infarct with scar present both in the endo and the epicardium. There was no inducible ischemia on the stress MRI, no hiatal hernias were noted, and the left lobe of the liver was not prominently present. The 3D reconstruction of this particular MRI was done, which suggested dense scar as well as scar, which was present in the territory of the right coronary artery, along with extending on to the lateral wall of the left ventricle. Our setup for the procedure was mainly vascular access in the femoral veins, the left femoral artery, as well as the right internal jugular. We also had a right femoral artery access for retrograde mapping of the left ventricle. Epicardial preparation for access was performed. The patient was kept under anesthesia, general anesthesia, after the induction of the VT at the beginning of the case, and we used CARTO for mapping. Epicardial access was taken after inducing this VT, which was similar to the clinical VT. Cycle length of the VT was 360 milliseconds with a QRS duration of 156 milliseconds. Pericardial access was safely taken, and a dry access was confirmed, and a Gillis sheath was placed in the pericardium with a catheter in situ. At the baseline, in sinus rhythm, these signals were noted. The AH and the HV intervals were normal, but I'd like to draw your attention to the signals within the CS, where between CS5-6 and CS7-8, the ventricular signals were extremely fragmented, were late, and were prolonged in duration, suggestive of potential areas of interest on the epicardium in the CS. This again confirms the presence of arrhythmogenic substrate potentially from the pre-procedure imaging. An endocardial substrate map was created, which confirmed the findings on the pre-procedural imaging of the substrate being in the territory of the RCA, especially in the inferior, infero-posterior, and the lateral LV, towards the base, more towards the base than towards the apex. This was similarly confirmed by the 3D reconstruction, which showed more dense scar towards the annulus as compared to the lateral wall of the left ventricle. We did create a late potential map by playing around with our settings on the LAT activation scale. We measured the distance from the reference at the peak of the QRS to the end of the QRS, and all points annotated after the QRS were colored purple. So the late activation again was concentrated in the region in and around the mitral valve in the posterobasal part of the LV. Fractionated signals were also noted in this location, which were long in duration and present after the QRS. Comparing the endocardial substrate map and the late potential map, there was concordance between the two. VT was then induced, and during VT, the signals noted on the epicardium on the CS catheters were similarly delayed and were present in the diastole of the ventricular tachycardia. Similarly, in the endocardium, we were able to find signals which were just presystolic. The region in between these two remained to be mapped. The endocardial site where the previous signals were noted is as shown here. Entrainment was carried out at this location. Capture was confirmed. The entrainment visualization was suggestive of a manifest entrainment with signals with a 10/12 correlation. The post-spacing interval, however, was less than 30 as compared to the tachycardia cycle length, with the signal, the stimulus to QRS equal to the EGM to QRS, that is 0, suggestive of a possible entrance site of the circuit at this location. We continued mapping during the arrhythmia, which was tolerated well at this point of time with vasopressors, and we came across these signals which were further into diastole as compared to the previous sites. The location of these signals on the activation map were as shown, and entrainment performed at this site showed a similar 10/12 to 11/12 manifest entrainment with a short PPI minus TCL with a stimulus QRS equal to EGM to QRS of around 60, suggesting that perhaps we were still in an entry site, but more towards the exit or towards the isthmus as compared to the previous one. At site 3, we got a site with similarly fragmented electrograms, which was more into the diastole of the ventricular arrhythmia than the previous site, which was close to the site as noted previously. And entrainment at this site yielded similar result with a even more longer stim to QRS of 80 milliseconds. Again, suggestive of a site within the isthmus, closer to the isthmus, but more towards the entrance than the exit or the isthmus. We then started mapping epicardially, where we were able to demonstrate signals which were late in the abnormal rhythm, which were mid-diastolic, early systolic in timing, which were fragmented and mid-diastolic, and even systolic, thereby completing the gap in the signals that we noted during the arrhythmia. We decided, therefore, then to transect the circuit after confirming the location of these sites with entrainment. Prior to ablation, we did a coronary angiogram and demonstrated that the proposed sites of ablation were far away from the coronaries. The tip of the catheter is noted here on the septum. Pacing for splenic was not performed since it was not on the lateral wall. The sites of ablation as compared to the endocardium versus the epicardium were as shown below. These sites were ablated sequentially and connected to the valves or to the basal part of the heart. During the ablation lesions, tachycardia terminated, and this was the site where tachycardia terminated. The line of ablation was not ceased and was continued to complete the line. This was the point of termination of the tachycardia. I would like to draw your attention to the signal at the time of termination, which is mid-diastolic. Also, the tachycardia terminated in the diastolic limb of the circuit, where there was no conduction into this signal after the termination. Absence of this signal led to termination of the tachycardia, and the local activation of the signal is actually late in sinus rhythm. Ablation was done at a 30-watt power at an irrigation of 5 ml per minute using normal saline. This signal is actually present in the time between the CS78 late signals and the previous signals which were located just before the QRS and in the presystolic location, suggesting that this was the missing piece of the jigsaw as seen from before. Post-ablation, there was non-inducibility demonstrated, two-side stimulation at 2 cycle lengths up to 3 extra stimuli. The sheaths were removed with a figure-of-8 suture for the venous sheaths, and the arterial sheaths were left in place. The epicardial sheath was removed after confirming no bleeding or collection of fluid. Glucocorticoids and lidocaine was instilled intrapericardially. Pain relief was given abundantly, and colchicine was also added to prevent further pericardial adhesions. Anticoagulation was given for a period of a month. Additional substrate ablation on the endocardium was also performed, taking care of all signals which were late, fractionated, and low in amplitude. In summary, for unstable VT, VT can be induced as a template and then cardioverted. Elimination of late potentials and fractionated signals are a must in order to have non-inducibility at the end of the case. If VT is persistent, we need to check the cycle length, reinduce it for short periods of time, and map alternate sites during the induction. Only ablation at sites within the VT may not terminate it. We may need to transect the isthmus before the VT is actually terminated. Spot burns may not actually terminate the ventricular tachycardia. Thank you.